Thank you very much indeed. It's a great pleasure to be here, and I'm delighted I was invited, as it's been a very interesting day. I thought it might be helpful just in terms of setting the scene to explain how genetics is commissioned within the NHS. And medical genetics, by which I mean both clinical and laboratory genetics, are one of 74 specialised services commissioned directly by NHS England. So at the moment, primary care doctors do not have any role in terms of defining our budget and how it's spent. And in England, there are 17 regional genetics centres, I work at one of them at Guy's Hospital in London, that provide these clinical and laboratory services. And I chair what's called the Clinical Reference Group for Medical Genetics, which is the group that effectively advises NHS England on what it should be commissioning. And our membership is a mixture of senior clinicians and scientists from around the country, representatives of 4 professional bodies, such as the British Society of Genomic Medicine. We have 4 patient and public engagement representatives who play an extremely important role, and both public health and commissioners as well. And the proposal, which is currently out to consultation, is that in the future representatives of CCGs, so effectively GPs, will also start to be involved. And that seems to me to be appropriate with what is often termed the mainstreaming of genetics, by which I mean increasingly genetic tests are not just ordered and requested by clinical geneticists like me, but by a whole range of healthcare professionals. So I'm not going to go through this in detail, but effectively looking at part of the job description for the role of the chair of a clinical reference group maybe helps to describe the sorts of things that we do. Effectively, we're providing, I suppose, hopefully informed clinical leadership to NHS England, both in terms of what is available now and what is likely to come up in the future. And we are specifically tasked with describing exactly what commissioners should commission and how you can assess the quality of those services. So the products that the Clinical Reference Group has produced include a service description, which tells commissioners exactly what they should be funding, what sort of staff there should be in the centres, what sorts of tests should be available, and that helps them identify how much that's likely to cost. I was asked earlier what the budget is for medical genetics in England. When I took on the role, it was about 96 million. It's now gone up to 126 million pounds per annum. We have defined a quality dashboard, which, just like your car dashboard, at a glance means that you can determine how individual services are working. And then these awful letters which people struggle so much with, sequins and quit proposals. Sequin is all about commissioning for quality, innovation and payment. Effectively, those are additional sums of money that are made available to departments who are not yet managing to deliver something but being encouraged to do something that the commissioners would like them to do, and if they deliver that, they get paid extra money. And then quit proposals, I suppose in a nutshell, are ways that we identify of trying to save money across the service so that it can be invested elsewhere. And we have one this year around Fragile X testing. At the moment, or in the past, paediatricians who had a child with unexplained developmental delay tended to do 2 tests simultaneously, chromosome analysis and a Fragile X test. Chromosome analysis will make a diagnosis in around 25% of cases, Fragile X in less than 1%. And so what we've done in London is said to doctors, send us the single blood sample and we'll do the chromosome analysis first. And then only if that's negative and there's good clinical reasons to suspect that the child may have Fragile X, will we then go on to do the Fragile X test. That saved a lot of money in London, and that's now being rolled out nationally, and it is anticipated that that will lead to a saving of just over £900,000 per year, because it will very significantly reduce the number of Fragile X tests that are done nationally. Now, I'm going to talk about 2 key partners of the Clinical Reference Group and explain their role, and you've heard both of them mentioned already today. The first one is the UK Genetic Testing Network, which was set up a number of years ago now, and has as its objective the promotion of equity of access to genetic advice, diagnosis and management for patients and families affected with genetic diseases. And by that they usually mean rare genetic diseases, which is defined as diseases that have an incidence of less than 1 in 2,000 in the population. So the UKGTN has a number of roles, and I would strongly urge you to look at their website if you haven't done so already. You'll find their lists of all the laboratories that are members, all the tests that they offer, how much each laboratory charges for each test, which very effectively drives down prices, because those that charge more than others find that they no longer get the samples sent to them for analysis. But perhaps the most important role in the context of today's meeting is the evaluation process for new genetic tests. And all new tests that labs and clinicians would like to start offering go through a formal evaluation process at UKGTN, and then once a year UKGTN recommends to NHS England which tests it thinks should be commissioned. These applications are called gene dossiers. They're quite tricky to write. You have to do quite a lot of work thinking not only about the specific test but at the various points in patient pathways where it would make most sense to use them. And ultimately what is developed is a series of test criteria which can be helpful for clinicians who are wondering whether to do a test and want to look up and see whether it's considered appropriate to offer that particular test to a patient. And the last full summary we have September 2013, that's because September 2014's decisions haven't yet been formally approved for commissioning from the 1st of April. As of September 2013, the recommendations included approaching 700 different disorders, well over 800 genes, because of course some disorders have more than one gene. And what's increasing the most rapidly at the moment is the number of panel tests using next generation sequencing. And if you look at all the different genes included in the panel tests as well, we're looking at a detailed evaluation of something that's been done for around 1,400 different genes. So the blue dots on this map, I hope you can see it, show you where the regional genetics centres are. The red dots show you where there are specialised biochemical genetic laboratories. They're dealing with the rare inborn errors of metabolism. And the black dots are specialist genetic laboratories. So in London, that'll be things like the Queen Square Neurology DNA Lab, the Bart's Retinoblastoma Lab, and so on. Just in case any of you are not familiar with this framework, developed initially by the Public Health Genomics Foundation, the ACCE framework, we are encouraged to consider, first of all, the analytical validity of a particular test, its clinical validity, its clinical utility, which is a different thing. And there was a question earlier from Catherine about whether the gene dossier process really does look at ethical, legal and social implications. It does when appropriate. For example, it will not approve tests that would be illegal in this country, such as tests that would help support social sex selection for women who are pregnant. It'll also consider whether for certain tests that identify a predisposition to an adult onset disorder, whether it's appropriate to offer that in childhood. And if it isn't, because there isn't any particular screening you would introduce, then obviously that would not be approved. So if you want to look at the PHG Foundation website, you'll find a little tutorial there about the ACCE framework. So, as well as needing to know about the particular disease for which a genetic test is being developed, you also need to think in the context of the healthcare setting as to how that would be helpful. And the UKGTN also looks at the specific laboratory that's offering to do a new test. How many is it done as part of its pilot? What sort of results did it get? Are the results credible and reliable and reproducible? And before it makes recommendations to commissioners about commissioning a new test, it also considers what would be the impact of not providing this test. How much would it matter? Would there be any significant problems if that were the case? And so when you fill in a gene dossier application, you have to know about the prevalence of the condition, how serious it is. You have to consider a number of different situations in which a test might be offered. Is it for diagnosis when it's difficult to make a diagnosis clinically? Does knowledge of a particular mutation help establish prognosis or affect management in some ways, perhaps by indicating other things for which screening might be indicated? Is it a condition for which pre-symptomatic diagnosis is considered appropriate because you would start screening or therapy earlier? And of course the possibility of prenatal and indeed pre-implantation genetic diagnosis. The price of the test is also considered, and I will show you some worked examples afterwards that also demonstrate how we make an attempt. It may be clumsy, but I think it's an exercise worth doing, to identify not only what the cost of that test would be, but if the test is done sufficiently early, what other diagnostic tests could perhaps be bypassed, therefore ultimately leading to some sort of saving. So we define very carefully the population of patients for whom a test should be offered and describe what particular clinical conditions, how they may manifest, because from time to time clinicians find themselves trying to diagnose a condition that they may actually never have seen before, and when you're dealing with rare diseases, that in itself is quite a challenge. So in terms of clinical utility, how can a genetic test be helpful? Well, it may alert comorbidities that the clinician might not otherwise have been aware of, and that could lead to additional screening. And in due course, that can affect morbidity and mortality. As I've suggested, avoiding diagnostic procedures is particularly beneficial if those diagnostic procedures are invasive, even more so when the patients concerned are children. And it is quite astonishing sometimes with patients who have very rare diseases, if you go back and calculate how many hospital appointments they've had and how many investigations they've had before they actually achieve a diagnosis. You've mentioned the social benefit of genetic testing, and it is impossible to evaluate quite what it means to parents to at long last have a specific diagnosis for their child who has some very rare disorder. It's not something you can put a monetary value on, but parents tell us it makes an enormous difference having a label for their child, having something that they can put in the box on the DLA form when they're making an application, knowing which patient support group they can join, because they feel it gives them legitimacy to join a particular support group if one exists for that disease. And of course, as geneticists, we're never just thinking about the single patient, we're also thinking about the extended family, and once we know which mutation or mutations are involved in a family, we can test other relatives and see whether they have inherited the same thing as well or not. Those who have may need to be enrolled in screening programs. Those who haven't can be discharged from follow-up. And for things like some of the cardiac conditions which predispose to sudden death because people develop ECG abnormalities in later life, there are some patients being followed up very regularly, every 6 months or a year, for years and years and years, and that in itself has significant cost. And if genetic testing will identify 50% of that cohort as actually not at risk, then clearly that's very beneficial. Now, once a test is on the UKGTN portfolio, these are the sorts of forms that you see. Don't worry that you can't read it. There's the name of the gene at the top. You fill in the patient's name, postcode, who the person referring it is. The third box down here says referrals will only be accepted from one of the following. So for this particular condition, clinical geneticists, paediatric neurologists and adult neurologists. So those are the only three groups of doctors who are permitted to request that sort of test. And the box at the bottom I've expanded here. So when people submit a sample for genetic testing, they have to have thought about these very specific questions. And you'll see these are very detailed, and you'll understand why for this particular genetic test it would only be a neurologist or a geneticist who would probably be in a position to answer those questions. And so people refer to these testing criteria, and it helps them think about which other sorts of clinical evaluations they should do before proceeding to genetic testing. So here's an example of a child who eventually achieved a diagnosis having had a 45 gene epilepsy panel on. This is a 7-year-old boy who had been undergoing investigations for the cause of his severe epilepsy, global developmental delay, microcephaly for 6 years, and had had numerous inpatient and outpatient investigations, 36 outpatient consultations, 3 admissions. His DNA was run through the epilepsy panel and found to have a pathogenic mutation in this particular gene, SLC9A6. That means that he has something that's eponymously named Christian syndrome. And we now know that he has an X-linked recessive disorder. His mother was tested. She doesn't carry the mutation, so she could be reassured that the chance of this happening in any future children that she might have was extremely small. He had an older sister who was about to get married, for whom that knowledge was very, very important, because she had confessed that she probably would not dare risk having any children had there been any possibility of them also being affected. And more specifically, in terms of his management, we knew that he was at particular risk of developing spasticity of the lower limbs, and so he was referred for very detailed physiotherapy. I'm going to show you another example with some sums here. This is something I'm particularly interested in because I specialise in inherited kidney disorders. An 11-year-old boy who turned up with unexplained blood in his urine and a family history of chronic renal failure. And in the past, in order to make a diagnosis, he would have had a renal biopsy and he would have had his eyes looked at with a special type of ophthalmoscope, because there are pathognomic changes in the eye in patients with Alport syndrome that you never see in any other renal disease. And those combined 2 investigations, one of which is highly invasive, a renal biopsy, would have cost just under £3,000. It used to cost us £1,000 per gene to screen the 3 type 4 collagen genes that are involved in Alport syndrome. But when we introduced next-generation sequencing in the clinic 2 years ago, we were able to put them all on a panel. We can now screen all 3 genes for £750. And so every child who now presents to the paediatric nephrologists with unexplained blood in their urine should have this £750 test. No kidney biopsy, no eye examination. And you can very easily do the sums and see how much money that potentially saves for our paediatric nephrology colleagues per year. But there's an additional benefit to knowing the mutation in this sort of child, and that is that you can screen adult relatives who may be willing to act as a kidney donor. This boy is inevitably going to develop kidney failure, although with early diagnosis and the early introduction of a type of drug known as an ACE inhibitor, we can postpone the time at which he reaches end-stage renal failure by between 15 and 18 years. That's a huge difference. That means instead of going into renal failure at an average age of 21, he'll be well into his 30s. A living-related kidney transplant costs £27,000, and then it's about just under £7,000 per annum for the immunosuppression to stop them rejecting the kidney. Whereas if he goes on dialysis for 20 years at a cost of nearly £24,000 a year, clearly that's much more expensive. So being able to identify non-carrier relatives who could give him a kidney means that he will get a much better quality of life because he'll have a kidney transplant rather than being on dialysis, and the NHS will save a lot of money. Here's another example. Boy presented at the age of 3 with short stature, slow weight gain. He'd got a big liver, so people were fairly convinced from a very early stage this was one of the early inborn errors of metabolism, but by the age of 16 he still had no definitive diagnosis. He had siblings who were getting ready to have children of their own and wanted to know what the risk was. And so we screened his DNA on a particular gene panel that seemed appropriate for a child with these sorts of symptoms, and managed to identify that he had glycogen storage disease type 6. This is an 18 gene panel. Over the 12 years, without the genetic test, he'd had just under £15,000 worth of specific investigations. This 18 panel gene test costs around £1,000. Now, this test has only become available very recently, but at least it means that children presenting as he did when he was 3 can now go straight to this test rather than having all these investigations first. And we are starting to see that implemented in clinical practice in a very effective way. So the gene dossiers that were summarised by last September went to the NHS England Clinical Priorities Advisory Group, and we are waiting for their view on that, and they will be considering both resource implications and clinical utility. And just as a summary here, last year 48 gene dossiers were submitted, 45 were approved, of which 17 were thought to potentially lead to savings across diagnostic care pathways. Many of these are for very rare disorders. For 29 of them, we would anticipate fewer than 50 index cases per annum, and 23 of them, and that proportion is increasing, are for panel tests. So how does the clinical utility split up? I won't go through all these in detail, but we look at whether these tests are likely to alert clinicians as to the possibility of comorbidity, whether it'll help with targeted therapy, whether it might reduce multiple hospital admissions, whether it'll be useful for cascade testing for other members of the family, and so on. And of the summary that was presented to NHS England this year, within specialised services such as clinical genetics, paediatric neurology, metabolic medicine and so on, we're asking NHS England for an investment of £512,000 and have identified that along the care pathway as a whole, this could lead to savings of well over £3 million. And before we could submit that data to NHS England, we had to ask all our colleagues in the other specialised services whether they agreed with us that the sorts of savings that had been identified would really be achieved in the care of those patients. And then for the ultra-rare diseases, the highly specialised services, we're asking for an investment of £43,000 for a potential saving of just over £1 million. So there's the UKGTN website. The other group I want to mention that we work with, and I know there are a number of representatives here, is the Public Health Genomics Foundation. And Gurdeep, who chaired the last session, did a really useful study for us at Guy's. And if you've got any questions about that, please ask him, not me. But looking at the costs and benefits of array CGH, which is a genome-wide screen of chromosome imbalance, as compared with the old-fashioned way of analysing chromosomes, which was called a karyotype. And inevitably what happens in the NHS is that we've had karyotypes forever, and so when the arrays came along, they were introduced as an additional test rather than initially replacing karyotyping. Although at Guy's we did actually swap to using arrays as a first-line test quite early on. And the cost of an array ranges hugely depending which part of the country you're in, from 190 to well over £1,000, an average of £291. Whereas if array is done as a second-line test following karyotyping, of course with 2 tests it's considerably more expensive. Looking at 2 large groups, arrays alone made a diagnosis in 11.44%, whereas the combined double test made a diagnosis in a slightly smaller proportion. So the cost per diagnosis for array as a first-line test is significantly less at £2,500 than the cost per diagnosis for arrays as a second-line test. And Gurdeep calculated that between 2009 and 2013 we saved £2.1 million in clinical and laboratory costs. And there's the reference at the bottom if you want to have a look at his paper in more detail. And the way we've used that money internally, in fact, was quite significantly so that we could invest in more next-generation sequencing and move towards increasing the use of gene panels. So I hope I've managed to persuade you that genetic testing in the NHS facilitates faster diagnosis and supports management of patients with rare diseases. It helps us know who should be screened for what. We use it a lot for cascade testing of close relatives once the specific mutation in a family is identified, and discuss with all patients who have a significant risk of having a child with a serious genetic disorder what their reproductive options might be, and of course for some of them the opportunity to consider prenatal diagnosis or pre-implantation genetic diagnosis is very welcome. Thank you.
Thank you, Frances.